Thank you to everyone joining us today for Aspire's webinar with Dr. Susan Swedo. For those who are new to Aspire, I'm going to just provide a very brief overview of our organization, and then Dr. Swedo will get started. So at Aspire, we empower and connect our community with tools and resources for advocacy, education, support, and awareness. We know that PANDAS is a devastating disorder, but recovery really is possible. And we know that early diagnosis and treatment can lead to improved outcomes. So at Aspire, we aim to improve lives of those affected by PANS and PANDAS by helping to close the gap between the onset of symptoms and the start of treatment and support. We have programs that reach 5 core audiences to increase awareness and understanding on a national level while providing critical support to all members of our community. We are fortunate to be able to be supported by our professional advisory board and all of our volunteers. So we are able to present the programs that we do today. For the national general public, we have awareness campaigns and educational outreach. For families and patients, we have one-on-one support, educational programs, and for our parents and adult patients, we have a Facebook group that you can join, and along with a few new programs launching soon. For schools and educators, we have a lot of toolkits and handouts for schools, but we also provide in-services to educators and nurses for free, thanks to our donors. Plus, we have lots of information for parents on the website, and we recently added a few new sections. For legislators, we have information on how to get started in the legislative process. If you're in a state that doesn't have anything happening already, and a team, I highly suggest that you look at some of our resources. We also create state pages for the boots on the ground state leads so that they can put all their information about call to actions about different legislative matters. And then we spend a lot of time talking to legislators on the phone and writing letters in support for different bills. And as far as our providers and clinicians programs, we recognize that our providers have a tremendous amount on their plates as they care for our loved ones. So we have started a program in which we provide doctors and therapists with literature on PANDAS that they can hand out to their families. Our webinar series that we're launching today with Dr. Swedo's talk, we've divided it into 5 categories so we can support many different audiences within our PANDAS community. So we have the 5 categories are treatment and scientific updates, behavioral health, integrative medicine, school support, and family and patient support. So you can look on our website. I'll be dropping some links as we go along into the chat. Dr. O'Hara is coming up at early May, and Dr. Lindsay Wells later in May, and then we have a few schedules working for June and beyond. So without further ado, I'm honored to introduce Dr. Susan Swedo. At Aspire, we are fortunate to have had Dr. Swedo not only encourage us to found Aspire in the first place, but also she sits on our board as a provider outreach chair and leads our professional advisory board, which is working on several important projects for our community. She is the Chief Science Officer for PANDAS Physicians Network. She's able to devote so much of her time to these 2 organizations because she recently retired as Chief of the Section on Behavioral Pediatrics at the National Institute of Mental Health, where she remains designated as a scientist emeritus at the National Institute of Health. Dr. Swedo is a board-certified pediatrician and received her medical degree from Southern Illinois University School of Medicine, and then completed her pediatrics residency at Northwestern University's Children's Memorial Hospital in Chicago, Illinois. Dr. Swedo began her career as a hospital-based pediatrician in Evanston, Illinois, and was later named Chief of Adolescent Medicine at the McGraw Medical Center of Northwestern University in 1986. She joined the staff of Child Psychiatry branch of the National Institute of Mental Health. And then in 1998, Dr. Swedo and her National Institute of Mental Health team first described pediatric autoimmune neuropsychiatric disorders associated with streptococcal infections, which we know as PANDAS. After a group of subgroup of children were identified as exhibiting a sudden onset obsessive compulsive disorder and other neuropsychiatric symptoms after group A streptococcal infection. Today, Dr. Swedo will speak on PANDAS, post-infectious basal ganglia encephalopathies. She will provide an overview of PANDAS, describing their diagnostic criteria, symptoms, disease mechanism, diagnostic process, and treatment. We asked for questions at registration. We got well over 300 questions, many of which will be answered within the course of her webinar. And then we will have time for some of the questions at the end, but we're certainly not going to be able to get to all of them. Hopefully one day we can just have a meeting with just question and answers and a short overview. So I'm going to stop the share screen and have Dr. Swedo share hers.
I changed the title slightly because I really want to focus on the difference between a disorder and a syndrome in this talk, because I think that having sort of collapsed everything into PANDAS, and we talk about it all the time like it's a single entity, but it's really not. Just a reminder that both PANS and PANDAS derived from our research on obsessive compulsive disorder that, as you heard, started at the National Institute of Mental Health back in the 1980s. We were looking for a medical model of obsessive compulsive disorder, and really our attention was drawn to Sydenham, Korea, for reasons you'll find out in a moment. But the thing that characterizes OCD in both children and adults is the presence of recurrent and intrusive thoughts or images. I mean, we all get the earworm, we all get that song stuck in our head. Imagine that that's there 24/7 and that you're trying to live your life around that. In addition, you might have repetitive, unwanted mental or physical rituals or behaviors. And for children in particular, these physical compulsions can have absolutely no obsessional thought associated with them. So it makes it more difficult for them to understand why they're having to do a certain movement or why they're having to react the way they are. In either of those cases, whether it's intrusive thoughts or behaviors, the child recognizes the symptom as senseless, irrational, crazy, and they try to hide it. And that's one of the things that can make it difficult for parents and certainly for clinicians to accurately diagnose PANDAS, is that it really depends on the abruptness of the onset of the symptomatology. And if the child has had semi-acute symptoms, subclinical symptoms for a while, and then they just suddenly or even gradually become worse and the parents become aware of them somewhat suddenly, then that can be a confusing picture. So let's get to what PANDAS is. As you heard, is pediatric autoimmune neuropsychiatric disorder associated with strep infections. And that name was chosen actually quite carefully, knowing that in Sydenham, Korea, there was evidence for autoimmunity. And we chose associated with rather than caused by, thinking that we were going to avoid some of the controversy that's ensued over the past 2 decades. If we could know now what we knew then, we probably would have called it autoimmune basal ganglia encephalitis or a post-infectious encephalitis. And we'll talk more about that in detail. PANDAS is a disorder. As I've already told you, we have an idea of what happens in the pathology of PANDAS, and we have a good sense of what is causing it. We do not have that for PANS. PANS is pediatric acute-onset neuropsychiatric syndrome. A syndrome is a collection of behavioral symptoms and signs or physical signs that always tend to hang together. And if you think about a syndrome similar to a constellation, you see Orion in the sky or Cassiopeia, and you know what it is by what it looks like. That's what a syndrome is. You have no idea what's causing it or what the disease mechanism is responsible. And if you think about the term cancer, that's also a syndrome. Cancer can have many, many different causes and different ways of being treated. Why do we lump them together? Because they're clearly different than other forms of childhood onset obsessive compulsive disorder and tics. The acuity of onset is truly the key here. And I fight with some of my colleagues all the time who want to expand the definition of acute to include symptoms that start over a period of many days or weeks. And that's just not acute. Acute onset is like your child having an ear infection. They're fine, and then they're in great distress. That's what acute means in PANS and in PANDAS. And it's important to make that distinction because it's going to lead us in a pathway that we wouldn't be taking for other things. And on this slide, I want to remind you that group A strep is just one of many different causes of PANS. Again, a syndrome, a collection of symptoms that hang together. The non-infectious triggers are just as important and just as real as the infectious triggers. And when families are really struggling to figure out what caused this and are really emphasizing that infectious pathway, it kind of makes my heart hurt because we have had children in whom there are very abrupt onset of OCD, separation anxiety, raging, behavioral abnormalities was caused by child abuse, particularly sexual abuse. And so you need to rule that out before you proceed down looking for an infection. Other environmental factors can also happen. Even losing a grandparent, a move, being bullied at school, all kinds of psychosocial stressors can do this. And as we go through the talk, you're going to hear that psychosocial stressors open the blood-brain barrier and allow these aberrant antibodies to enter. If those antibodies aren't there, even just the psychosocial stress, the adrenaline rush, and opening of the blood-brain barrier can be problematic. So again, not necessarily infection. PITANS, pediatric infection triggered autoimmune neuropsychiatric disorders, was the first one of these we described back in 95. And that case actually had children who had an abrupt onset after influenza, after chickenpox or varicella, as well as after group A strep. And we focused on the group A strep because of the fact that we had a prototype disorder. We had a model in Sydenham, Korea. And that Sydenham, Korea is the neurologic manifestation of acute rheumatic fever. You're probably more familiar with rheumatic heart disease, where the valves and the heart muscle are affected. But in Sydenham, Korea, the antibodies are actually formed that misrecognize human brain tissue as foreign and set up an inflammatory response. That work of the cross-reactive antibodies actually dates back to the 1950s and 1970s. And we've known for a very long time that Sydenham, Korea is the result of basal ganglia inflammation. There's been some argument about whether or not this is a good model for PANDAS, particularly when Russell Dale and his colleagues renamed Sydenham, Korea as post-streptococcal autoimmune encephalitis of the basal ganglia, a beautifully descriptive term. It actually completely encapsulates the pathophysiology that's at work in Sydenham, Korea. But as far back as the 1800s, the relationship with abrupt onset obsessive compulsive disorder has been described in Sydenham, Korea. And you can see from this rather busy slide that it wasn't as much a discovery as it was a reading the literature and putting 2 and 2 together to get 4. The fact that in some patients, they might not go on to develop the abnormal chorioathetoid movements that characterize Sydenham, Korea, because in every case that was described, the obsessive compulsive symptomatology started 2 to 4 weeks before the chorea began. And we really had this dose response curve in our heads where we were thinking that, well, if it's a less severe insult, perhaps you end up with OCD. Over time, over the past 3 decades, we've really come to understand it's probably a difference in the actual antibodies that are being aberrantly developed, and that may explain some of the differences in symptomatology. But fortunately for us, we had these historical reports showing that obsessive compulsive symptomatology was very often associated with Sydenham, Korea. In our own studies, about 2/3 to 3/4 of the patients had OCD, at least subclinically. And that's one of the questions you'll probably ask later. Can you have PANDAS if you don't have clinically significant obsessive compulsive disorder? And the answer is yes. Would you get the diagnosis in a research setting? Probably not. But oftentimes when we ask the children to add up their symptomatology, it comes to well over an hour, even if it seems relatively mild. Our very first case of PANDAS was actually referred to our study that we were doing on treatment of Sydenham chorea. And that trial was described by Marjorie Garvey and was a very successful trial comparing prednisone versus IVIG versus plasmapheresis for kids with Sydenham chorea. And this little boy was sent in with these flailing arm movements that looked very chorioathetoid, which is described as writhing, purposeless movements that interfere with your function. And he indeed had those, except when you watched them for a period of time, it became very clear that he did the arm movement the same way every time. And in Sydenham chorea, you are absolutely unable to predict what that next movement is going to look like. His dysarthria was actually because he was talking with a mouth full of spit. And when we really delved into his history and convinced him that his crazy symptoms were probably not going to be that new to us, we discovered that he had severe hoarding rituals, that he had a compulsive need to perform this arm ritual, and he was actually flinging germs away from his face when he did that. Two different neurologists from the Movement Disorders Clinic of the National Institute of Neurologic Disorders and Stroke did an exam of him, found absolutely no evidence that he had chorioathetoid movements. He had a positive strep at the NIH. We gave him antibiotics to treat that, and by the time he came back for follow-up a month later, his symptoms were markedly improved. So not only was he our first case of PANDAS, which we hadn't discovered at that time, but he was also the first child with PANDAS to be treated effectively with antibiotics. Well, over the next 5 years, we recruited a group of children with abrupt onset symptomatology and described, as you heard in 1998, the first 50 children with PANDAS. 5 research criteria were required. One was presence of OCD or a tic disorder. And if I could live my life over, I would have left the tics off. Dr. Rappaport, our supervisor and mentor, told us to not include tics because it would keep it out of the neurology realm and maybe would have kept the controversy from happening. But we did, because at least a third of the children were presenting with a primary tic disorder. And we didn't want to leave them out of the opportunity for treatment. As with Sydenham chorea, they had to have prepubertal onset. In work by Fischetti and others at Rockefeller University, they had shown that 98% of the population has antibodies against the conserved portion of the M protein of the strep by the age of 12. What that means to you is they were immune to strep by age 12. But you're thinking, oh, I'm still susceptible to strep. I get it every time my child gets a strep throat. And unfortunately, it appears that that's the group of individuals who may be more prone to develop PANS, is those who aren't making that protective antibody response. The acute onset was very crucial, again, as we've already described, to distinguish it from other cases of obsessive compulsive disorder. And as we watched these children over time, it became clear that their episodic course wasn't the waxing and waning you see in Tourette's or even in OCD, where environmental stressors, a bad day at school, can make things worse. There's a diurnal rhythm where they're fine during school hours and then they're worse at nighttime. That wasn't what we were seeing. What we were seeing was that the child would go from 0 to 100, stay there, gradually get better, maybe go back to their baseline completely, and then they'd have another big blow and they'd have an exacerbation. That's called a relapsing and remitting course. And as we know from multiple sclerosis, that is one type of presentation. And Jenny Frankovic has gone on to describe not only the chronic static, which is children who go and they don't come back to their baseline, but also chronic progressive, where each time they have an exacerbation, their symptoms worsen and the baseline that they return to is higher than the one before. We try to prevent that by treating the child early in the course of illness. And even at the point that they are chronic progressive or chronic static, Dr. Frankovic and her colleagues at Stanford have shown that there is good response to treatment. So many of the questions were around what is long-term outcome? And the answer is it's expected to be quite good for this group of patients. Association with neurologic abnormalities, their choreiform movements, fine piano playing movements. They're not these writhing movements that interfere with function, although the choreiform movements may be contributing to the handwriting deteriorations that we see. And then finally, a temporal relationship between symptom exacerbations and group A beta hemolytic strep infections. This has been soundly criticized in the literature, and I think it's because they don't know the literature well on the pathology of the group A strep and of Sydenham chorea, in which there can be a lag time of up to 5 to 9 months between the inciting strep infection and the onset of the chorea. Presumably, it's because the inciting strep infection is the one that's known, and there's been a secondary one or another infection that's triggered that same innate response. I get so excited talking about this, I'm probably way behind time, but Gabby will push me along if she needs to. PANDAS clinical presentation, we've already talked about the relapsing remitting course. These are young children. Our youngest patient was probably 2, but we counted the first one as a 3-year-old. And the mean is 6.5. So it's that first grade, second grade. Interestingly, when we went into the schools to do tick counts on every class from kindergarten through 6th grade, it was the second half of kindergarten, first and second grade, where we were seeing the most tics and ADHD-like behavior. And Tanya Murphy's work at the University of South Florida has confirmed that in a separate study looking at the relationship between strep and tics. Boys outnumber girls by about 2.5 to 1. And the thing that's really become clear that is distinguishing of PANDAS isn't just the acute onset. It's the fact that the children get sick in multiple spheres at the same time. They don't just get OCD and tics, they get emotional, behavioral, cognitive, and physical symptoms. And those are the things that began to really form that constellation that we talked about that describes PANS. Here's a slide showing the frequency of comorbid symptomatology in the PANDAS cohort. And what you see is that for separation anxiety, nearly every child had at least some separation anxiety. Behavioral regression, sleep disorders were present in 80% of the children. In that study, we included refusal to sleep alone there, but it could have just as easily gone into behavioral regression. We've subsequently learned that over 80% of the children have abnormalities on their sleep studies, on their polysomnograms. So a sleep disorder in 80% is accurate, even if you take that out. Inability to concentrate, new onset of hyperactivity and inattentiveness, again, in the majority of patients. Notice here that eating disorders were present in 20% of that original population and hallucinations in 10%. And that PANDAS related psychosis, hallucinations, and delusions, they're quite unique, quite distinctive. They are scary, but they're not a bad prognostic sign. It's just, again, evidence of acute brain inflammation. Miro Kovacevic was the one who first noted the terror-stricken look, the dilated pupils or mydriasis, and that hyper-alert fight or flight appearance in 80% of the children. That's there very briefly, and you might actually miss it in your child. Probably the most pathognomonic sign is the urinary frequency, urgency, and enuresis, and we'll talk more about that in a few moments. Just want to mention handwriting deterioration, again present in 90% of the children. And if you have the opportunity to look at our children's school, they kept the journals at the school, but you might have homework papers, and what you'll see over time is a change, fluctuation in the quality of the handwriting. Lisa Snyder, one of my fellows, compared that with strep in that child and their family members and found a very tight correlation between periods when the handwriting deteriorated and when strep was in the home. Sensory hypersensitivities or insensitivity. Insensitivity is much less common. What we typically see is the child becomes acutely sensitive to light, noise, sound, and particularly textures. Just like children with Tourette's are described to have difficulties with the feel of their socks or their waistbands. Some children actually can wear only a single pair of pajamas, silky pajamas, because that's the only thing that feels okay against their skin. Well, when we looked at these in categories, and these 7 categories are the ones that define the categories of abnormality in PANS, we found again that on average, children had 5 of the 7 categories of symptomatology present at our cohort at NIMH, in Miro Kovacevic's sample in Hinsdale, Illinois, and in Beth Latimer's sample when she was still in Bethesda. The constellation is quite rich. In an individual patient, it may look very different than the next patient over. And what they all have in common, by definition, more than necessarily by pathophysiology, is the presence of obsessive compulsive disorder, and in PANDS, eating disorders. And we included eating disorders as a core symptom because it became clear that that group of patients was quite severely ill and would benefit from treatments that we've been using for PANDAS just as much as those with a primary diagnosis of OCD. The other thing is that the dividing line between OCD and eating disorders, just as the dividing line between OCD and tics, is completely blurred. And they have so many features in common that I think it's an artificial construct to describe them separately. So for PANS, we described it as the very abrupt onset. My scholar colleague, Paul Grant, found the word foudroyant, which means lightning-like in French, and it is indeed like a lightning strike. The children are struck down by the abrupt onset of OCD or eating or fluid intake restrictions, plus at least 2 of the 7 categories. And as you've already heard, on average, they're going to have 5. So we may actually change that to 3 of the 7 just to help give people some clarity. Very important not to forget that third criterion. The symptoms are not better explained by another illness. Remembering that PANS is a syndrome, all you do when you make a diagnosis of PANS is describe what's happening in the child. And somebody asked about insurance. One of the best ways to get insurance coverage is not to use that umbrella term of PANS, but instead to delineate the specific disorders that are present. Separation anxiety disorder, obsessive compulsive disorder, ADHD-like behaviors, and all of those have separate diagnostic codes, which, thanks to the Parity Act, are payable by insurance. Here's an example of the dysgraphia. On the left is a child before their symptoms began, and during the acute episode, it looks like he's just rushed through and completely done a terrible job on this homework. In actual fact, trying to draw that graph on the right took him almost twice as long as labeling the parts of the microscope. Behavioral regressions can occur, and many of you have seen this slide multiple times, but it still always is remarkable to me how this drawing looks like it was drawn by a 3-year-old, and then after IVIG treatment by Dr. Kovacevic, she's back to drawing her hearts and flowers and the artistic abilities of the 9-year-old that she was. Tanya Murphy was administering the Ray Osterrish complex figure test to children. This is a test of working memory, and the actual task is to reconstruct this complex figure 5 minutes after you've drawn it on paper. But what she was astute enough to notice was that the children didn't have that spatial orientation to be able to copy that figure faithfully, and more than 80% of the patients in her study scored below the first percentile for the copy task. Beautiful way to very quickly ascertain whether or not a child has this kind of dysfunction. Unusual margin drift is something that parents pointed out to me. So again, it shows the importance of listening to parents as you're taking histories. And what they would describe is that the child was getting notes like in that right-hand paper. How about starting your sentences at the red margin? Very gentle teacher. I have one in German where she was not as gentle and said, move to the left. The child can't. And what that's an example of is left-sided neglect. In its extreme cases, we've actually had children who, when you ask them to draw a clock face, put all of the numbers on the clock over on the right-hand side. Deficits of executive function. These are neuropsychological tests that look at strategization, organization, planning, all the executive functions that allow us to get along in a very complex world. And what you see is that the pattern in PANDAS and Sydenham chorea is more alike each other and quite different than those children with Tourette's syndrome and ADHD, even though the kids with Tourette's had movement disorders and the ADHD had impulsivity severe enough to be in Dr. Judy Rappaport's study. And the difference there is that the response execution task, where the children are just pressing go, no go, go, no go, is one that is hard for the children with Tourette's and ADHD to perform, but they do okay when you ask them to change up fingers and respond 1, 2, 3, 4, and then the next time 2, 3, 4, 1. Whereas in the PANDAS Sydenham group, that response selection task was distinctly abnormal because they have an inability to simultaneously inhibit and exhibit behaviors. I told you we'd come back to the urinary symptoms again, because I consider this to be the pathognomonic sign. If your child has an abrupt onset of OCD, perhaps accompanied by some anxiety, some depression, some emotional lability, and they don't have any physical symptoms, the chances of them having PANDAS is relatively low, because at least 80% or more of the children will have some kind of urinary symptomatology. And the most classic is the child who just develops a very sudden onset of quite extreme urinary frequency, where they're going to the bathroom multiple times an hour. And most importantly, for boys, they feel like they still need to void at the point that they've already urinated. And we think that's because the internal sphincter is under differential control than the external sphincter, and what they're trying to do is voluntary control of the urine, which is then in the urethra of the penis. It is important to look and make sure they haven't gotten urinary tract infections, since urinary frequency and incontinence is certainly a sign of a UTI, but the urinalysis will be normal and the culture will be negative in these children. Sleep disorders, as I've already mentioned, happen in more than 80% of the children, possibly closer to 90%. They might have trouble falling asleep, and a child who used to fall asleep in 10 or 15 minutes is now taking hours to get to sleep, or they wake up in the middle of the night and they can't get back to sleep. Or most difficult for many parents, they wake up at 4 o'clock in the morning and they are awake and anxious, might refuse to sleep alone, and they have very restless sleep. When we did the polysomnography, and the study was published by Dr. Ashura Buckley and our colleagues at NIMH, we found that these children were failing to establish atony or muscle paralysis during rapid eye movement sleep. And rapid eye movement sleep, or REM sleep, is that period when you are thought to be dreaming and you're paralyzed in order to not act out your dream. Some of the sleep medicines like Batuta and others give you warnings that you may actually be acting out your dreams or moving about during REM sleep. And in these patients, fortunately, they're not getting out of bed, but they are continuing to move during REM sleep. They also have periodic limb movements of sleep. This can be a sign of iron deficiency, particularly ferritin deficiency in the brain. And so if you see PLMS, it's important to make sure that the iron levels are normal or optimal. So that was a lot of information, and most of it was me talking about the symptoms. And these were really nicely summarized in the consensus statement. I say nicely summarized, but that's a really long article. And I urge you to either get that article or, more importantly, go to the PANDAS Physicians Network website. And there's a beautiful flowchart there that sort of walks you through the diagnostic steps. Because the medical evaluation of a child with PANDAS must be comprehensive. Again, this is a diagnosis of exclusion. You have to rule out everything else before you can make this diagnosis. And you want to make sure that you haven't missed something that's, frankly, not controversial, and more importantly, would be treated differently than what we're going to propose. So you get a comprehensive history, including the family history. The importance of that is you can often get clues from the fact that about 20% of relatives of a child with PANDAS will have had a childhood history of OCD or tic disorders themselves. Many have outgrown it. Some continue to have difficulty even as adults. You want to do a physical exam, looking for the choreiform movements, dilated pupils. What we're now finding is also postural orthostatic tachycardia syndromes. You actually want to make sure that their blood pressure is remaining stable when they go from lying down to standing up, because if they have POTS, that can complicate treatment. And it tends to be more common among those who are presenting closer to adolescence. And you also want to do a physical exam looking for occult infections, certainly looking at the tonsils. You probably can't see the adenoids, assessing whether or not that child might have a sinus infection. Sometimes that requires CT or an MRI scan, and then examining the urethra and the perianal region to make sure they don't have perianal urethral strep. And then finally, you want to rule out Sydenham, chorea, and other illnesses. And the differential diagnosis is quite long. Most of these diagnoses on this list can only be excluded with laboratory tests. And so the laboratory evaluation of a child with PANDAS is relatively complete. And again, that's delineated at the PANDAS Physicians Network website. Of these, the one I want to mention is systemic lupus erythematosus, or we would know it as lupus. This is initially diagnosed by a positive anti-nuclear antibody test, but over half of our children with PANDAS and about 60% of children with Sydenham chorea have a positive ANA, as do about 5 to 8% of the healthy controls. So just finding a positive ANA is definitely not a sign that the child has lupus and it requires further testing. And in fact, finding a positive ANA is good evidence that you do have a lot of cross-reactive peripheral inflammation at work, and may be a peripheral sign that there's neuroinflammation as well. We want to do a swallowing study if the child is presenting with an abrupt onset of food or fluid intake restrictions related to a fear of vomiting or choking. Many children have an obsessional fear of vomiting or choking, so it can be difficult to distinguish this. But in Sydenham chorea, about 20% of the children have an abrupt onset of dysphagia, which is just described as an incoordination of the voluntary and the involuntary musculature of the esophagus. And since Sydenham chorea is characterized by involuntary movements being set off by voluntary movements, it makes sense that that would be happening in the esophagus. And if that's present, then you're going to be wanting to treat with a neuroleptic or other treatment to really try and tamp down that response. Polysomnography, it's amazing to me that people aren't able to, still aren't able to get sleep studies because of the COVID pandemic. They've actually improved the technology to allow home sleep studies. And so it's something that I think should be done on more of our children with PANDAS because it can be so illustrative. An EEG is probably not going to be helpful if it's just a routine, lay them down for 20 minutes and do an assessment. But if you can get a longer study, you may indeed find evidence of epileptiform activity, spike and slow wave progressions, or even areas of regional slowing, as we had seen in our patients with Sydenham, parietal, temporal, and other regions that can be affected. An EEG cannot obtain tracing from the basal ganglia. It's too deep in the brain, so it's not going to tell you what's going on there. And then finally, a lumbar puncture is my personal belief, based on a long time of clinical experience, but I am very concerned about children who are getting IVIG or more aggressive therapy who have not had a lumbar puncture done, because we really need to rule out encephalitis, meningitis, other things that can give you a presentation of abrupt onset of neuropsychiatric symptomatology. If you're going to do an LP, the cerebrospinal fluid absolutely has to be sent for antineuronal antibody panel. There are more than 50 forms of antibody positive autoimmune encephalitis that have been described, and it's very possible that one of those is present in a child who's presenting as a PANDAS. All right, we already talked about the EEGs. Lab tests. Oh, this first one I get asked all the time. Do we do anti-streptococcal antibody titers? In general, no, but you do a throat culture, and probably not just on that child, but on all of their close contacts if possible. Certainly on siblings that are sharing a room with them. You want to make sure that there's not strep in the child who's presenting with the symptoms, and not in the home, because any kind of exposure is going to provoke the ongoing antibody response. Why do I not think that they need to have titers done? I'll try and keep it brief, but the bottom line is that the ASO and anti-strep DNase B are the only ones commercially available now, and they miss almost as many infections as they pick up. And you can only consider it to be a positive titer if you've seen a rise in the titer of at least fourfold if the samples are not batched and twofold if they are batched. And so you have to do 2 blood draws to get that. You have to catch the inciting infection early enough in the process that you get the first one before. And the bottom line is that most children have a positive ASO, positive anti-strep DNase-B, just because they're children and they've been exposed to strep. It's becoming true again. The COVID pandemic and all of the isolation and restriction was really a godsend for children with PANDAS because they weren't seeing as much strep. And it was interesting, my colleagues were not having very many new onset cases present during that first year of the pandemic. Again, indirect epidemiologic evidence that this is indeed related to strep. We already talked about the ANA, or the anti-nuclear antibody tests. The molecular lab assay can be helpful. I think that it often is over-interpreted, and that's partly because of the way the test is reported out, with that yellow zone suggesting that those titers are of concern. In actual fact, just as the ASO and anti-strep DNase-B are only helpful if they're rising, the molecular lab assay is most helpful if you have a high CAM kinase 2 activity, because that's indicating that whatever's present in the serum has some degree of bioactivity within the cell. Here's another example of why those titers aren't very helpful. On the top is a child who has PANDAS, and what you see is that the symptom severity actually goes up in that red line about a month before the titer should increase. The strep infection actually happened right here. And the second strep infection happened right there. And the titer, if I could draw the line straight, it would have gone straight. This, the symptoms go up and then the titer rise follows. If you measured it here, symptoms are sort of coming down and the titer is still quite elevated. Or if you measured it here, you would see that symptoms were high, but the titer was still low. And in the non-PANDAS patient, it's even more obvious that there's no correlation at all between the strep and the symptomatology. The red line is the Watt-Yale-Brown obsessive compulsive symptom severity. This child has some pretty significant differences in severity over time, almost a 40% difference from one point to another, but there's absolutely no association with the time of the infection here and here. All right, if we can come back to that if we need to at the end. I mentioned the CAM kinase 2 activity. Important to recognize that this threshold was set at 140 because none of the control patients had levels above that. I think that the experience at Molecular has been able to bring that down to 135. So there's going to be some PANDAS that get missed at 135, but most important on this test is that you are specific with that result, because you're trying to determine whether it's PANDAS or not, and that would mean that most children would be above 140. All right. So let's go on to treatment. There's a three-legged stool shown here because that's my best analogy that I could come up with for what is required in treatment of PANDAS. And there are 4 articles in this series that were developed by members of the PANDAS Clinical Research Consortium. And the first one is just an overview stressing the importance of all 3. And when I see families who've been with a PANDAS expert for years and have only been depending on immune treatment, it makes me very sad. Because even in our children participating in the studies at NIH, as soon as they finished the blinded phase of the trial, we, as rapidly as possible, got them into psychiatric care with use of SSRIs and cognitive behavior therapy, specifically exposure with response prevention. I know from experience, and I know from the data, that we have to go after all 3. You have to treat the source by treating and preventing infections. You have to treat the immune system dysfunction, and it's incredibly important to treat the symptoms. If you don't treat the symptoms, the child suffers unnecessarily, and you've really missed an opportunity to get that child into a complete remission. So I'm going to hammer on my desk and beg you to move ahead with finding a well-qualified cognitive behavior therapist. The International OCD Foundation, iocdf.org, has a wonderful resource list of individuals, and they even sponsor an annual CBT ERP training course for pediatric providers. And so there now are pediatric providers across the country with telehealth. You can do some of it by telehealth. It's a little bit difficult if the child is not willing to really fully engage, because they can kind of fake it, pretend to do the exercise below camera and not actually do it. But an experienced therapist will catch them. And then psychotropic medications. It's very important. It's emphasized here to start low and go slow. It's impossible to guess what dose is needed for a child or even adolescent with PANDAS. So our best guess is that you start somewhere below 1/4 to 1/5 of what is typically a starting dose for an individual. If you start too high, particularly with the SSRIs, the specific serotonin reuptake inhibitors, you are going to cause activation, which can make that child feel worse. You aren't actually worsening the illness, they just are feeling worse during that time. A lot of folks get scared because we use antipsychotics. Obviously, if the child's having hallucinations and delusions, that's an appropriate treatment. But the primary treatment actually for the movements of Sydenham chorea is Haldol, is an antipsychotic. And so that label has been replaced by dopamine receptor activating drugs. Anxiolytics, in children, we don't tend to use drugs like Valium and clorazepam and others, but because of the REM behavior disorders in this group of patients, that may be appropriate. We'll talk about the rest in a minute. So I really want to start again by emphasizing it. We put it as the first leg of the stool in our series of 4 articles. Again, start low, go slow, exposure with response prevention. That combination, not just in children with PANDAS, but in all children with obsessive compulsive disorder, was found to get more than 2/3 into remission by the end of a 16-week course of cognitive behavior therapy. So within 3 to 4 months, you can have your child's asymptomatic. And when that happens, if the child's asymptomatic and you think, oh, maybe there's still some neuroinflammation going on, what you've done then is to give their brain a rest. And we typically ask parents to maintain those medications, the CBT, until the child has been asymptomatic for several months. And then you can begin to let up on other things. If they have another flare, then you actually have the tools in place to respond quickly. If you've been flare-free for a full year, then you can start to taper down the SSRIs and get rid of those. And I promise you, they're not going to have to be on them for their whole life. Antibiotics. This was the one among the consortium members that we really struggled with the most, because we are pediatricians and we are called to be good stewards of antimicrobial use. The AAP literature is full all the time about debates whether or not we're treating otitis media, ear infections, with antibiotics now. Is the risk-benefit ratio favorable? Well, it's certainly the same thing for this group of patients, because we don't have necessarily an antimicrobial responsive infection as the trigger for PANS. We might not even have an infection as all the trigger. And so we had to depend on some indirect data, as well as a beautiful study done by Dr. Tanya Murphy, in which she took a group of PANS patients, regardless of whether or not they met criteria for PANDAS, and put them into a double-blind placebo-controlled trial of antibiotics, and found that the group receiving antibiotics for a month did better than those who didn't. It may not be the antimicrobial effect at all. It may be the fact that all of the amoxicillin, certainly augmentin and azithromycin, all have immune modulating effects that may augment their antimicrobial infections. But the consortium came down and published the recommendation that 3 to 4 weeks of treatment level antibiotics at the initial diagnosis was useful enough to be warranted. Use of long-term prophylactic antibiotics is not appropriate for any children who do not fully meet the PANDAS criteria. And the full research PANDAS criteria require 2 episodes both clearly triggered by a group A strep infection or exposure. If you don't see it in the affected child, then you need to look in their family members. You want to eradicate the infection with 3 to 4 weeks of antibiotics. Probiotics can be helpful to protect the gut flora, and you just administer them the way you would any other antibiotic. Because you want to try and keep the gut healthy, we try to keep with very narrow spectrum antibiotics, ceftonir, which is one of the cephalosporins, azithromycin, good old amoxicillin, moving to augmentin very rarely because it is pretty wicked on the gut. And I would say rarely, if possibly never, a role for antiviral or antifungal therapy. The number of children who have had an abrupt onset of PANS following a fungus is minuscule. If it follows a virus, the viruses that I mentioned, influenza, varicella, all of the rest that have been shown to trigger these kind of symptomatology can't be treated with an antiviral because by the time you get around to treating them, they're gone, number one. And number two, we don't have any antivirals that directly impact them. And I know there are clinicians that are using both antivirals and antifungals. I hope that they have a good rationale for that because to date, there is no data that that's helpful. And we've already talked about long-term antibiotic prophylaxis. If you actually want to do it correctly, you have to use intramuscular bicillin because it's the only one that's been shown to have a peak trough that remains stable enough to keep strep at bay. Those IM bicillin shots are pretty painful, and most families can't do that every 3 weeks for a full year or more. However, in Italy, that's their treatment of choice, and Fernando Falcini and her colleagues used IM bicillin in 371 Italian children with PANS-PANDAS and found that symptoms were markedly reduced for more than 80% of the patients. All right, one that everybody thinks about when they think about PANDAS is use of immune therapies. It's the sort of new thing that we added. Actually, I would have said the new thing was the antibiotics, but certainly the immune therapies are used only for this group of patients and not other psychiatric patients. And it includes non-steroidal anti-inflammatories, good old Motrin, Aleve. Aspirin could be used, except there's a prescription against it because of the association with Reye's syndrome. But aspirin was actually always the best treatment for acute rheumatic fever. And I would love somebody to be brave enough to do that study and see if it would be helpful to our children with PANDAS. But to date, I haven't been willing to do it, and nobody else has either. Antihistamines be useful. If you came on early, you may have overheard Gabriella and I chatting about that because it is allergy season. That's the cause of my frog in my throat this morning, is that the trees are budding here in Virginia, and they definitely stimulate the immune system. H1 blockers are the Prevacid, Rantac, other things to block stomach acid, and H2 are the typical antihistamines that you think of, everything from Benadryl to Zyrtec and all those in between. If a child has a very allergic pattern, getting ahead of those allergies with use of antihistamines can be quite helpful. We haven't actually seen it helpful in a child, let's say, who has their onset of PANS-PANDAS in October, clearly related to a strep, no fall allergies. We don't typically turn to an H1 or H2 blocker. Except for the H1 blockers, the stomach acid blockers need to be given at the same time you're giving that month-long course of nonsteroidal anti-inflammatories. Jenny Frankovic's work at Stanford has shown that we should all be considering a short burst of oral steroids. We use them all the time in children with asthma, so I don't know why we're reluctant in our kids with PANS-PANDAS, but probably because in psychiatry, there's so much concern about the fact that steroids can cause activation, almost a hypomania syndrome, where you're just loose and not sleeping and all the rest. It doesn't appear to happen if a child truly has PANS-PANDAS. And so the chances of them having an increase in their rage, an increase in their out of control behavior is quite low. And the chances of them having a more abrupt cessation of their current episode is quite high. If oral prednisone isn't appropriate or available, IV steroids can also be used. Dr. Frankovic looked at those as well. If the symptoms are in that moderate to severe range, the child's not getting to school, certainly beginning to worry that they're not even going to be able to get out of their room, then I would definitely be thinking about IV steroids and a prolonged course of steroids where you really want to keep that immune modulation in place for a month or more. Intravenous immunoglobulin has received a lot of attention. Our most recent trial failed to show a significant improvement over placebo. And that's the one that's being quoted the most by pediatricians and others, and should be. It was a failed trial, not the negative trial that it was interpreted to be. And it was failed because A, we didn't have enough kids in the study, and B, we hadn't done a careful enough job of controlling for infections coming in. So we had 2 children in whom, when we treated them with antibiotics, their symptoms improved, and unfortunately they were randomized to the placebo group. That sounds like excuse making, and in some ways it is, but the reality is that the initial trial that I'll show you the results of should have been sufficient to show the importance and the help of using IVIG. I'm asking you to reserve it just for the acute treatment of a child with moderate to severe symptoms, because that's the only thing we have data for. And IVIG does carry the risk of giving that child an occult infection. I mentioned our Sydenham chorea study. In that study, we actually were giving IVIG and gave 2 of the children hepatitis C because there wasn't a test for it at that time. And there was a lot of the gamma guard, the IVIG coming out of Sweden that had been infected by a single donor. So 1 donor out of the 20,000 that contributed their immunoglobulins to that lot managed to pass that virus on to others. We now can test for most known viruses, and IVIG has been improved by opsonization and other cleaning procedures, so it's much cleaner. Molecular weight is used to determine that it's actually only immunoglobulin G going in there, but again, it can be problematic. So just hold that threshold. If the child really has PANDAS and they have moderate symptoms, I have no qualms about giving it. I am very concerned about some of the questions that came in where a child has been receiving monthly IVIG for 10 years for PANDAS. That is completely outside anyone's experience and the data, and would suggest that either that individual had an immune deficiency that was being treated by the IVIG and they should get the right diagnosis, or there was a failure to adequately utilize the other 2 legs of the stool. Do we ever repeat doses of IVIG? The answer is probably we should. And there's a new trial for any parents who are on here whose child has been recently diagnosed and they haven't yet received steroids or IVIG. There's a trial underway by Octagam that is enrolling currently only in Arizona, but there's going to be 5 more sites coming online across the United States in the next few weeks, including Boston and other sites, where they are doing a trial of multiple doses of IVIG to see if 2 or 3 doses is superior. In life-threatening cases, my personal preference is to use therapeutic plasmapheresis, the blood cleaning procedure, where the child is hooked up to the apheresis machine that is normally used for donations, and the blood is spun. The liquid portion, the plasma, is taken off. It is replaced with albumin and fluids. The red cells, white cells, and platelets are returned to the child. And in doing that, you actually not only remove the circulating antibodies, more than 90% of circulating antibodies are removed by a 4 to 5 5-round course of plasmapheresis, but you also activate the cytokines and other immune components and return them into balance of the self versus other. How do you decide which one to use? The main thing is the presenting symptoms and the duration of illness. In the mild symptoms, you use the least invasive therapy. And the PANDAS Physician Network, again, provides, in this case, not a flow chart, just a summary document that talks to you about how to treat mild, moderate illness, severe illness, and then the extreme or life-threatening. And finally, probably the most important thing is the availability and affordability of proposed treatment. And this is why I've been really emphasizing the difference between PANS and PANDAS. If you have PANDAS, whether it's, I should just say PANDA or PITANS, if you have evidence that you have a post-infectious encephalopathy or a post-traumatic encephalopathy, and you have evidence that you've got neuroinflammation, then you should be advocating hard for that immunomodulatory leg of the stool. And the diagnosis would be that post-infectious encephalopathy. If you have PANS, it might not be so important to be advocating for that until you have evidence that there is immune dysfunction going on. And so in that case, the month of antibiotics plus an aggressive start with the treatment with medication and cognitive behavior therapy may be sufficient to get that child's symptoms under control. Absolutely do not pursue immune treatments if your child doesn't meet criteria for PANS PANDAS. In a very brave study, Judy Rappaport and first author Rob Nicholson and our group looked at 5 patients with very treatment refractory OCD. This paper was published in 2000, but it was done in the mid-1990s. Very bold that we were able to get permission to use a 2-week course of therapeutic plasma exchange in them. It had performed the best in our control trial, and we wanted to give it the best shot. They went through the whole plasmapheresis, central line insertion, and all the rest, and the children had absolutely no improvement. So most invasive, most immune modulating treatment that we could use in non-PANDAS, PANS, OCD had no impact. And so if you're not seeing a benefit from IVIG or steroids or other immune therapies in your child that you think has PANS, PANDAS, one of the first questions should be, is that the right diagnosis? It just doesn't help. All right. Management with other things, melatonin may be helpful. Benadryl has the additional benefit of being an antihistamine. The caution with both of those is that the effect wears off after a few nights, so you want to probably use it sparingly if at all. Neuroleptics or the antipsychotics, please don't shy away from them if the child has severe movements or even those psychotic symptoms that we were discussing. And we advocate some kind of supportive care for the parents, regardless of what's going on with the child, because it's really tough to have a child with PANS PANDAS. And you need to know what to expect over the course of the illness. That's where Aspire can be so helpful. Other families have already walked this road and can give you their guidance and their help. I actually am quite concerned about some of the Facebook groups, so be judicious when you join them, because you're likely to find out things that are just plain crazy. There was a time camel's milk from China was being advocated as the treatment you had to get for your PANS PANDAS child. Not true. And I think that we can get off course there. So be careful with that. And if possible, as you're signing your child up for that cognitive behavior therapy, I would urge you to have the first couple sessions to be for the people providing the care to that child, so that you can really learn how to practice the tough love. How do you distinguish between something a child has to do and something that they're just doing to be because they're the sassy 6-year-old that they were before they got sick? And then advocacy with the school system is crucial. Again, a number of questions about that came in ahead of the webinar. And the general management and accommodations, Gabby and the folks at Aspire are provided already some hints on their website, good resources there for the schools as well as for you as caregivers. And the main thing here is that any 501 or IEP really needs to take into account that this is a relapsing and remitting illness, and the accommodations might be needed at some times and might be hurtful at other times. And so you really want to educate the school on what's happening and work with them as much as possible. But in general, you really have to choose the battles that are worth fighting and those that you have to let go, including the fact that school refusal becomes a primary symptom in a lot of these children. And how do you even get them to school? That was certainly compounded by the school closings associated with COVID. Dr. Doran has written a good book that's helpful for educators. But again, if you go to aspire.care, they have toolkits available for working with the schools, school psychologists, as well as the individual teachers. And just to close, I just want to talk about the fact that this PANDAS is a treatable and preventable illness. With antibiotic treatment and prophylaxis, we can actually prevent future episodes. Hear all the time about younger siblings having their first blow or their first episode of PANDAS. And in those cases, when you get right in and find the strep, eradicate it, treat that child, and then remain vigilant against future infections, the child has absolutely no presentation of their PANDAS. Immune modulatory therapy can help to address the abnormal immune response. And seeing that slide reminds me of two things that were also prominent in the questions. One was the role of tonsillectomy and adenoidectomy. The Georgetown group feels very strongly that tonsillectomy is beneficial in this group of patients. And they've shown that the T cells and as well are abnormal in those tonsils, as well as the fact that there are abnormal bacteria present in the tonsillar tissue, even without obvious crypts and abscesses. Probably more striking evidence comes from Ratan Agalu and his basic science team at Columbia University, who were able to show that for repetitive infections of the nasal-associated lymphoid tissue in mice, and the NALT is the equivalent of the adenoid, were sufficient to induce the production of these strep-specific T cells that trafficked along the olfactory nerve into the brain. So some good kind of circumstantial evidence. The reason I say it's mixed is that Dr. Murphy's experience and mine was the opposite. And we have an older group. We had an older group of patients in whom we were looking at them from initial onset forward, and had a number of children in whom the tonsillectomy actually removed the only sign that they had a strep present, because the tonsils didn't get inflamed and they didn't know that they had strep, and they actually had either had onset or worsening in association with the tonsillectomy. So I think the evidence is mixed, suggests that you get the second opinion and really make the decision on the basis of they've already got indication on because of sleep apnea, or the tonsils are enlarged and evidence of recurrent strep infections. The second one was Rituximab. And this was something that we were all extremely excited about a few years ago. There had been two anecdotal cures, two at Stanford and a couple in Beth Latimer's group. And we thought this might be ideal because Rituximab is a monoclonal antibody that basically destroys all the plasma B cells, and thus destroys that ability to have that sending out of all of the troops that reinitiates the immune response that can trigger a flare. The problem with it is that these are children at the time in their life when they need those kind of memory cells present to keep from being infected with the same organisms they've just seen the year before. And secondly, that it is a fairly chronic treatment for a fairly acute problem. You don't even begin to see benefits from rituximab for the first 3 to 6 months after you've received that initial injection, and then they recommend that you continue it for at least a year. And so I think without some good hard data showing that it's truly a benefit, the risk probably outweighs the benefit. But for individual cases, I think it's something you have to talk to your clinician about. All right, I think I should stop. Do you think, Gabby, and take the questions? Because yes, we're
Yeah, or you could answer this question, because I think this is one of the things that has come up in a lot of the questions. So,
okay. Which question? Oh, is PANDAS a form of autoimmune encephalitis?
yes.
Okay. Okay. I shouldn't have gone so fast through all those slides. We'll just do the first 4. What is autoimmune encephalitis is probably the first question we need to ask. And it's basically a constellation. It's a syndrome described as a disorder because you have some idea what's going on. But all of these brain disorders are characterized by autoimmune induced neuroinflammation. And in the case of adult autoimmune encephalitis, it's typically actually a non-infectious trigger. that gives rise to the AE, or autoimmune encephalitis. The most common thing in adults is actually teratomas, abdominal tumors that produce, uh, provoke the production of antibodies that then cross-react with normal tissue. Antibody positive cases account for only about half of the cases. And Joseph Dalmau and his colleagues were the first to describe anti-NMDA receptor antibodies. And that's still to this day, probably the most classic presentation of autoimmune encephalitis. But that means that half of the cases are antibody negative, and they're much more difficult to diagnose because you don't have any kind of confirmation. Because of that, the AE community of physicians has decided that there are 3 criteria for making a diagnosis. One is clinical presentation. Do they fit the picture? And the picture is a semi-acute onset over the course of a few days or a couple of weeks, or acute onset of a complex set of behaviors. So PANDAS has that by definition, as does PANS. They need to have abnormalities of the paraclinical studies or the lab assays, and they need to have a response to immunomodulatory therapies. So is PANDAS a form of AE? Absolutely, based on the clinical presentation. We have the acute onset of symptoms in multiple domains: cognitive, emotional, behavioral, sensory motor, and somatic. Specifically, you see memory and concentration difficulties similar to those described now for long haul COVID, which everybody is feeling is probably an immune mediated disorder. Handwriting changes, the insomnia, certainly the somatic symptoms of urinary frequency and the sensory changes, and then the evidence of these neuropsychological deficits. Do we have the paraclinical support? Yes, and that's what the next few slides are going to show. And then we've just talked at length about the fact that we have a very specific and selective response to an immunomodulatory therapy. So this was the trial I mentioned that was so convincing in the first place because response to placebo IVIG administration was 0, as opposed to 45% reduction in IVIG with IVIG and more than 60% reduction with plasma exchange, with a number of the children becoming asymptomatic by 1 month. The dysgraphia can respond to treatment. The caudate size can change. Now, I need to caution you, this is the only child to date in which we've been able to visually see it. So you're doing an MRI with contrast, looking for, actually, you're looking for other causes of the abnormalities that we're describing as PANDAS. But in this boy, following successful treatment with plasmapheresis, he went from 100% of his waking hours being occupied by exercising rituals, symmetry concerns, checking concerns, to almost none. And his caudate shrunk by 20% back down to expected for his age, sex, and weight. Harry Shigani and his colleagues showed the same kind of changes with PET, positron emission tomography. Unfortunately, we can't get this study done in children because there just aren't normals for comparison. But those of you who are overseas might be able to get a PET study done. We've talked about the changes in antibody titers. This was the change in the Y-box scores in that failed IVIG trial. And what you see was that actually everybody got better once they had received IVIG. And their ANA levels fell. If they were positive ahead of time, they had more improvement than if they were negative ahead of time. Antibodies are present in the CSF as well as in the serum, and have been shown by Madeline Cunningham and her colleague Christine Curvin, now by Chris Pittenger and the group at Yale, to be recognizing antigenic or neuronal structures within the basal ganglia. Nadine Hornig and Ian Lipkin and that group, when they were still out in California, showed that actually if you took our kids' serum and put it into a group of mice, induced the abnormalities, and then transferred that serum to another group of mice, you presented, also transferred the stereotypies and the behavior changes that had been seen. Very interesting. In this group of mice, as well as a group that was studied in Israel, they hadn't recognized this as a symptom, but it was just so profound when we were sitting around talking that these mice also had eating restrictions, and several of them starved to death. They actually had to change the way they tested them, because if they were withholding food prior to the maize test, then they couldn't get them to eat afterwards. I've mentioned Dr. Aglio's work with the recurrent strep infections, weekly injections into the nasal-associated lymphoid tissue, producing these strep-specific T cells that were definitely problematic in that they were producing the neuroinflammatory cytokines. So we really have all 5 levels of evidence: the clinical observations, paraclinical evaluations, demonstration that this is an antibody positive form of autoimmune encephalitis, as well as the fact that immune therapies improve it. And Russell Dale has proposed that strep Sydenham chorea be post-streptococcal basal ganglia autoimmune encephalitis. And I think we can put PANDAS and some presentations of PANS into that group. There's a very large group of autoimmune encephalitides that are not going to meet PANS PANDAS. And those are the ones that I'm asking you to make sure that you've done an evaluation to rule them out. Okay, so now we can move on to the other questions, Gabby. Thank you.
Okay. So as I said in the beginning, we got over 250 questions. So obviously we can't answer all of them. I do know that Dr. Swedo did a good job of covering at least more than half of those questions. So I'm going to try to pull some questions sort of from each group that we put them in to try to sort of cover some bases. So let's start with the basics. We have a child with the sudden onset symptoms. How do we get our pediatrician to even talk to us about PANDAS, in your opinion, as a pediatrician?
So as a pediatrician, I would not want you to come in and say, I think my child has PANDAS. I would want you to come in and tell me how his behavior has changed, how his sleep has changed, how you're concerned about the urinary symptoms. Really parse it out into those that are brain-based, those that are the rest. If they sort of give you a little pushback, oh, it's just a phase, every child has a little trouble once in a while, you say, well, could we at least do strep? And it's interesting that in the DC area, at the Minute clinics with CVS, the nurse practitioners were actually doing half of their throat cultures for behavioral presentations, because it just became so well known that a strep infection could be producing ADHD-like behavior, as well as the OCD and some of the other concerns. So again, talk to them. Physical symptoms, I forgot to mention it, so I'm glad Gabby chose this question. A lot of these kids are going to have some fleeting joint pains. That's again a sign that they're in that rheumatic fever family. And so you want to focus on the physical symptoms, the cognitive changes, the behavioral changes, and just try to be as not matter of fact, but be as focused on what you have observed as possible, and try not to tell them the diagnosis. Because we mentioned a diagnosis of PANS is not actually helpful in coding and getting insurance coverage. So far, PANDAS is not either, unless you know how to code for it specifically.
And then what do you do if they don't do anything? Do you suggest?
If they don't do anything, well, you might have in your bag the diagnostic evaluation flowchart from the PANDAS physician. Just saying, I wouldn't bring it up first, but you might have it there and just say, can we discuss this? And one clue, again, from when I was doing general peds, they only have 5 minutes in that initial appointment. So maybe your only goal in that initial appointment is to present them with the problems, say, I've heard about this PANDAS, I wonder if it's a possibility. Can we schedule a longer evaluation? And they may appreciate that enough to do it for you, because again, pediatricians by nature love kids and they want to be helpful to you. You can also remind them how different your child looks today than the child that they've been seeing before. And fortunately, I think despite the fact the American Academy of Pediatrics still says there's absolutely no role for antibiotics for PANDAS, no evidence that strep is involved, that's in the official Red Book, and we have not yet received the AAP's decision from their work group trying to evaluate the controversy of PANS pandas, how they're going to come down. But pediatricians can't really be faulted for following the current AAP recommendations on this disease. What you can help them understand is that there's a burgeoning literature. Direct them to the PANDAS Physicians Network. If all else fails, ask to see somebody else in the practice. Nurse practitioners tend to sometimes be more open-minded, not always. And the other thing is that you may need to just invoke some help from Aspire, PANDAS Physician Network, or other organizations that have lists of clinicians who are sensitive. And then last resort, go to the emergency room. If you present to the emergency room with the kinds of behavioral changes, you may end up only getting a shot of something, but it is still a good resource.
So there was quite a few questions about comorbid issues around PANS and differential diagnosis. Is it typical? Can you have a diagnosis of Hashimoto's, ulcerative colitis, and autism and still have a diagnosis of PANS pandas? And then in a different
yeah, let's take the autism question first, because that's probably more common. So yes, children with autism absolutely can develop PANS pandas. Fairly classic presentation, might be difficult to see in a nonverbal child, but you will see the same kinds of changes in their behavior. Children with autism often have sleep problems, but now the sleep problem is different, and they're clingy in a way that they haven't been. They're repeating their rituals. The stereotypies might be much worse. Suddenly they're having the sensory sensitivity. So the types of symptoms that are happening in that autistic child are the same, as is the acuity of the change, because all of the symptoms of PANS pandas are also known comorbidities of autism. So the thing that would make it unique is that they're all presenting at the same time. Whereas a child who has autism and is becoming more obsessional and more fixated in their rituals and routines, that is worthy of treatment and should be brought to your doctor's attention, but is probably needing traditional anti-obsessional medications and to the extent possible behavior therapy, rather than going to the three-legged stool of PANS pandas. The question, I was fascinated with the question about ulcerative colitis and Hashimoto's and autism and pandas. I would say that you don't have to invoke PANS pandas there. You already have two quite profound immune disorders. And Hashimoto's thyroiditis is known to cause autoimmune encephalitis. It's known to have behavioral impact, as is ulcerative colitis. So you don't have to invoke PANS pandas. You would just talk about brain neuroinflammation secondary to ulcerative colitis and Hashimoto's thyroiditis. Again, to generalize that, good reminder that many things can cause this kind of neuroinflammatory change, which are already known, already treated. And if you called that example where it turned out the child had Hashimoto's and you just called it PANS pandas, ignored the thyroid, you can imagine the damage being done. So again, make PANS pandas your diagnosis of exclusion. And in that case, you already have other things that you can blame those symptoms on.
And just one point about the autism, our professional advisory board wrote a toolkit on PANS and autism on how to handle it. And it's a document that is written by doctors for doctors, and it's on our website in the toolkit section. So if you go to resources and click down to handouts, it's in there. And we will most likely have a webinar coming up on that specific topic at some point. There are a bunch of questions about tick-borne illnesses and PANS. We are having a webinar with in the end of May with Dr. Lindsay Wells, naturopathic doctor that works with Dr. O'Hara, who's on our professional advisory board. And she's going to be providing a webinar on PANS and tick-borne illnesses. And for the questions that fall more into the integrative care, Dr. O'Hara is speaking at a webinar for us on May 2nd at 4 o'clock. The Zoom registration is available now on our website for that one.
And
And
Dr. Shannon Doherty is also on the PANDAS,
right.
the Professional Advisory Board, and she heads the Lyme and tick-borne illness plus PANDAS clinic at Columbia University. So if you're in the New York area, that might be an additional resource.
And she has a couple of articles up on our website. Again, in that resource section on our website, you can click down to tick-borne illnesses. There's lots of articles on PANS and tick-borne illnesses, 2 from Dr. Delaney, very long from Dr. O'Hara, and a couple of others. So there's a lot of resources currently on there, and we will have webinars with all of those doctors within the next year or so. So question, comment on what symptoms are being observed in adolescents with post-infection flares from COVID.
I think that they run the gambit, at least from what I've been reading and hearing. So the most common one, they actually look a lot like the tick-borne illnesses, but the cognitive decline, the brain fog, the exhaustion, and just sort of lack of motivation is quite common. Obsessive compulsive symptomatology is not quite as common among the post-COVID neuropsychiatric symptomatology, but certainly the emotional, neuropsychological, and to some degree behavioral domains are impacted by that. And I think there are a number of groups across the United States interested in trying to understand this phenomenon. So I just urge you to look for one at a university-based center so that you are getting access to the best multidisciplinary care possible.
And then there's a lot of questions about recovery and what does it really look like? Will there be lingering symptoms? Will it continue to affect learning? Will, say, math skills come back? And what if we have almost returned to baseline in our children, but they continue to have lingering effects into post-puberty and even into adulthood? And how do you access care? And what kind of care should you focus on if and when those symptoms don't all return to baseline?
Great question. Completely individual. Our experience has been that if you do the full court press, you use all of the tools available, the antibiotics, the immune therapies, and very importantly, psychiatric medications and cognitive behavior therapy, you can expect your child to return to baseline. Will they have anxiety, depression, substance abuse, any of those other mental illnesses that appear during adolescence and adulthood? Possibly. They're just as much as risk for that as anybody else in your family. They're not protected by their PANS-PANDAS. Will they continue to have difficulties with PANS-PANDAS? It is possible that they will have to manage their symptoms of PANS-PANDAS into at least young adulthood. And we're trying to figure out if that's because there's been scarring and so this is the new normal. That's the most likely answer. And it doesn't matter because they respond exactly the same to the SSRIs and exposure with response prevention. So if I have a young adult who still has 5% of their symptoms left, I'd say get thee to a behavior therapist and work on those and get rid of them. If you really don't like them, if they, interestingly, after a while, they actually become part of me. And when Judy Rappaport and I went and did a follow-up study in a high school population, we found that about half of those teens that had met criteria for OCD at first survey didn't at second survey because they weren't ego dystonic anymore. They were taking the stairs instead of the elevator because it was healthy, not because they were afraid to touch the contaminated elevator button. So people live with a significant amount of OCD tic disorders, but I don't think you have to. We can get rid of those symptoms and you can expect a full remission. Does the PANS-PANDAS go away? Yes, there's no doubt that that initial aberrant response to an infectious trigger will disappear over time. It is the body, the immune system's job to recognize self as self and foreign as foreign. And the longer you can protect the brain, which is supposed to be a protected space from those antibodies and keep it from reactivating that immune response, the more complete the remission is going to be. But even if you had multiple infections, there will come a time when the body says, wait, that's me, and I'm not going to mount an immune response against that. So the immune component, the neuroinflammation, definitely subsides in a relative being a relative term, but a relatively short period of time. And then you're literally dealing with the symptoms in the aftermath. And so I think that the best course of action is to be aggressive with all three legs of the stool early on. At the point, continue those neuroinflammatory directed treatments as long as there's evidence of neuroinflammation, and that's some of the more physical symptoms, and then really depend on well-established effective treatments for the individual symptoms, the OCD. Use of stimulant medications for ADHD, to me, that's kind of a non-brainer because they work so well and they have so few side effects over the long term. They might cause some appetite suppression, other things that need to be managed, but you can try different compounds and find one that works. And does your child need to be on that cocktail of an SSRI, ADHD med, maybe a tic med, and an anxiety med forever? Absolutely not. You're going to continue it just for a few months after the symptoms have been completely controlled. And when we say complete, I mean 0. I don't want them to be lingering. You might pull the dose back enough that they have a little bit of symptoms, because that gives them something to work on in the cognitive behavior therapy. But you want them to give their brain a rest and let them move on. Long-term outcome, the only one that we've established in a group of adults, and granted, they were not treated for PANS-PANDAS, so we have absolutely no data on this in PANDAS patients, but it appears that the only long-term sequelae is a visual spatial skills deficit. And it's been rendered moot by GPS and by Google Maps, because what they couldn't do was read a map and then figure out how to go from that map in real life to make a trail. So if you got Google Maps, that deficit doesn't matter. The math skills will come back. It seems to be a short-term cognitive working memory issue, not a longer-term issue, but some visual spatial skills deficits may remain.
And then one question is about, you talked a bit about the genetic history and looking at all of that. So this sort of is an extension on that, is what is the likelihood of PANS-PANDAS occurring in siblings?
The best we can do is extrapolate a relatively small study and suggest that it may be as high as 20%. And that would mean that 1 out of 5 families are smaller now, so the individual child's risk is probably about 20%. We need a bigger study and better epidemiologic data, and the PANS Consortium is working with an epidemiologist at the University of Washington, Eric Masterson, who's put together a registry, and that would be helpful in terms of answering that question. Again, vigilance at that initial hint of symptomatology, and then watchful waiting. If they have a flare, get them in for strep cultures, perhaps do a short course of antibiotic treatment can be quite effective in preventing them from having the kinds of problems the index case or the first sibling did.
And then another about comorbid questions. Do you see a lot of joint pain related? And when would be a good time for a patient to possibly see a rheumatologist? And do you see a lot of chronic fatigue issues? Yes, we have the sleep difficulties, but then there are a lot of kids who have seem to be unable to actually stay awake for long periods of time. And it's a real fatigue issue. Even if they are awake, they're just completely exhausted.
Yes, so joint pain to start. Jenny Frankovic and her clinic that she follows of more than 200 children found that joint pains were quite common. And she's a rheumatologist, so she knew how to ask. And the questions that we had been missing were about back pain, which seems to be quite common in this group of children. Joint pains, particularly the migratory joint pains that you see in acute rheumatic fever, where one day it's the right ankle and the next day it's the left knee, and they never get red and hot like a true arthritis. It's just an arthralgia. But the back pain can be quite debilitating. And these kids talk about needing to get into a shower in the morning and let the hot water run on them until they feel like they can get moving again. They act much older than their years. That's well addressed by the immunomodulatory treatments that you're using for the neuroinflammation, particularly the non-steroidal anti-inflammatories. And sometimes that's the best clue that families have that the non-steroidals are working or that they're not working, is whether or not they're able to control the joint pain. I think the question about chronic fatigue goes right into that same category as the POTS, the postural orthostatic tachycardia syndrome, which is that you have some constitutional changes as a result of this, and they need to be dealt with as you would if you hadn't had PANDAS ahead of time. So POTS is becoming increasingly recognized as a sequelae or an aftermath of PANDAS. They have PANDAS when they're 7 to 10, and then they have POTS when they become teenagers. And the treatments for POTS, most importantly, is an accurate diagnosis, and then it's fairly easily treated with salt and fluid balances. And I suspect that a lot of chronic fatigue is falling into that category, because it's not so much well, I should change that. There are a group of children who it isn't just that they are sleepy, it's just that they have no energy and no ability to move and get out, and that's more the classic description of chronic fatigue. If you actually are seeing a child who is having excessive daytime sleepiness, Mignot and some of his group that studies sleep disorders out at Stanford has suggested that that may be an antibody-mediated form of narcolepsy. And so you really need to have a workup for that. And that's something that even neurologists will be able to respond to, is if you talk about daytime sleepiness, falling asleep without warning, and some of those symptoms of narcolepsy.
Okay, and then I think the last question, because of time, can you speak a little bit more to the psychosocial stress and how it opens the blood-brain barrier? And then if you're not treating an infection, what do you do with that other part of that treatment triangle that would normally be an antibiotic?
Okay, those are two different questions. So let's take the second one first. If there's no evidence of antibiotic at all, the only reason you'd be using the antibiotic is for an additional punch on the immune system. Azithromycin, amoxicillin, and some augmentin and azithromycin in particular are able to inhibit NF-kappa B, which is the initiation of the complement cascade, initiation of the innate immune response, whereas our other treatments are more focused on the adaptive as well as the innate. So you might get a little benefit from that. But if you're absolutely sure there's been no role for infection, then antibiotics are not necessary at that point in time. When we wrote the guidelines, we were really writing guidelines for treatment of first episode of PANDAS. And I think that when you get into the point where you're on your third or fourth or fifth episode, you should be seeking treatment from a PANDAS specialist. And at my last count, there are centers at universities in now 19 different states. So your chances of being able to find one in your region are pretty good. In addition, as you've heard from Gabby, there's integrative physicians who are specializing in this. One word of caution: if a naturopath or an integrative physician starts handing you a list of all of their proprietary supplements and all of the rest of the things they want your child to take, I would leave, because that is not necessary or helpful. PANDAS by definition is an acute onset illness in an otherwise healthy child if they haven't had the other things we've been talking about. So the needing to completely change their diet routine. Now that I've said that, I opened a can of worms that hopefully Dr. O'Hara will address in her talk, because there is sometimes a role for restriction of gluten, casein, and other things if the child has sensitivity to that. And that actually can develop during the course of the PANDAS because of the immune activation. The final question was supposed to be the first part of that, Gabby, and I've yammered so long I forgot it. But
well, so if the symptoms are triggered by psychosocial stress, what
psychosocial stress and the blood-brain barrier. Thank you. So let's take PANDAS as our classic example, because at least we know a little bit about what's happening there. In PANDAS, the inciting strep infection had on its cell wall proteins and glycoproteins and other stuff that it puts there to hide from the immune system. And it's a very clever technique. It's so effective that strep is one of the oldest bacteria, and it has no ability to accept viral compounds from other viral particles from other bacteria and that give it resistance. So that's why it still responds to treatment with penicillin. But what it does well is hide from the immune system, except that it doesn't. If that strep lingers long enough, then the body begins to recognize those proteins and glycoproteins as foreign, and they're really not. So they're foreign in that they're on the strep, but they're not foreign in that they're also on the heart or the brain or the joints. And so they form these aberrant antibodies that get into the circulation, and their job is to attach to something that they see as foreign and set off an inflammatory response and kill it off. Well, if you can't get into the brain, which is not supposed to happen, there's no problem if you have responded to GLEC or to the acetylcholinergic receptor or other compounds within the basal ganglia, because you're not going to see those antibodies in the brain. You won't have neuroinflammation. But any fever, any extreme release of epinephrine or adrenaline will open the blood-brain barrier. And bacteria actually make products that specifically open the blood-brain barrier. So it can open at times when it should be shut. Those antibodies get across, neuroinflammation is initiated. And as we've learned from Dirtan Agalyu's work, if T cells are also activated, you actually now have neuroinflammation that's completely independent of what's happening in the rest of the body. So the rest of the body might get tamped down, the neuroinflammation continues. Maybe it doesn't continue, maybe it's just quiets down. T cells are no longer producing the IL-17, no neuroinflammation, but those antibodies are still present in the brain, or T cells are still present. Next time the blood-brain barrier opens, move. The other problem with all of this is that we know from rheumatic fever literature that after that initial inciting event, that the aberrant immune response actually generalizes. So a virus can set it off. The psychosocial stressors that release epinephrine activate the complement cascade. All of that can then provoke a pro-inflammatory stance that can set things off again. And so it literally is a matter of tincture of time combined with our best efforts to try and suppress that aberrant immune response, get things back into the healthy balance that they're supposed to be, and then keep them there as long as possible. When there's a disruption, to again just tamp it back down as quickly as possible. And so this is a great question to be the last one. How would I manage my child with PANDAS who's had one bad episode but now seems to be in remission? I would get them off other things as soon as appropriate and possible, and then just practice good hygiene, not excessively obsessively hygienic, but just good hygiene. And anytime that child had a flare that lasted longer than 24 hours, then I would get throat cultures done on the child and the family members, and just start over again with that triad of, probably in that case, antibiotics, a non-steroidal, and reactivating their behavior therapy protocol. After they've done that a couple of times, you don't even have to do the antibiotics and the immune therapy. You can just do the behavior therapy protocol.
Okay, great, thank you. I'm sorry if we didn't get to all of your questions. Some of them were very patient specific, which Dr. Swedo can't, or any other doctor is not able to answer since you were not a patient of theirs. At Aspire, we will continue, like I've mentioned before, to have more webinars and create more toolkits on our website for all of you. I will just make one suggestion to piggyback on what Dr. Swedo just said. If you do not have a flare for a while, I love that. We love hearing that. My suggestion would be, especially in doctors that require you to see them every year in order to stay an active patient, do a quick check-in, even if you were paying out of pocket, because it can be a lot easier to get back into them when you suddenly are in crisis again. And I urge you to do that, not just for that, but so you can keep your current school letters, your letters current for each year. So at the end of June, it's the end, or May, if you live down south, it's the end of the school year. But immediately you need to have on your books a time to get a revised letter for your 504 and IEP. I find it to be very helpful than scrambling in September and trying to, oh, I need to get this again. So just that's part of a preventive measure, is to be able to have all your ducks in a row should you have a secondary or tertiary exacerbation. With that being said, thank you for everybody for coming. We will be putting this webinar up on our website. May take me a couple of days. Today I'm back-to-back meetings and webinars as well, so I know I won't be looking at it today. And have a few school lectures tomorrow. So look for it maybe next week, but we'll see if I get it up ahead of time. And, you can always email us at info@aspire.care, or my email is gabriella@aspire.care. Like I said, some days are talk days and some days are desk days. So if I don't get to hold of you that in a couple of days, know that I'm not ignoring you. I just can't even open the email to send it to somebody who can also help you, because I'm not the only person answering the emails, but sometimes I'm the gatekeeper. Anyway, we do the best we can, and I enjoy seeing everybody. And of course, you can, if you're a parent or an adult patient, please join our Facebook group and sign up for our newsletter so that you can stay up to date and sign up for upcoming webinars and see when we're dropping some new toolkits, which are coming out soon. Thank you, and good luck on your journey. And we all see you and know how hard it is, and we've all experienced it. And thank you very much for coming. Thank you, Dr. Swedo, for your time and all the work you do with Aspire and PANDAS Physician Network for the community, and for founding this horrendous disorder that we hopefully can treat and have had a lot of success with. So thank you very much for that. And my children owe you a lot.
I owe all of you a great deal too. Thank you all for coming.
Okay,
Have a
thank you,
blessed and
everybody.
wonderful weekend.